Hello. 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 Uh, Thanks for the patient hearing. This is the last topic today. It's about the ankle block. Moving from proximal to the distal part of the leg, the ankle block. The ankle block is a block of 5 nerves, so you require injection at 5 points. So it's a sort of a painful block, but it is very handy, very useful in certain cases. Out of the 5 nerves, as everyone knows, in comparison with the upper block, upper extremity, you need to block only one plexus, that is the brachial plexus. Whereas in lower extremity, you need to block components of both plexuses, that is the lumbar and sciatic plexus. So as you go distally at ankle level, the component from the lumbar plexus is the femoral nerve. So at this level is the saphenous nerve, which is a component of femoral side, that is the lumbar plexus. Whereas all other 4 nerves are from the sciatic component, that is the tibial nerve, deep peroneal nerve, superficial peroneal nerve, and sural nerve. This figure I have taken from one website run by Dr. Shiv Kumar. It shows the dermatomal distribution. This part is covered by superficial peroneal. This is by saphenous, that is the femoral component. Sural, the calcaneal nerve. This is medial frontal, lateral frontal, branches of the tibial nerve. Anatomy. Saphenous nerve is the terminal branch of the femoral nerve. The 2 terminal branches of the sciatic nerve, common peroneal, divides into deep peroneal and superficial peroneal nerve, and the tibial nerve, which innervates a large portion of the foot. At the popliteal fossa, a sensory branch emerges from it, the sural nerve, which anastomoses with the common peroneal nerve and goes distally. Indication: foot surgery without tourniquet, foot surgery with leg tourniquet of short duration, post-op analgesia, and rescue block if proximal block failure. There are no specific contraindications except infection at the injection sites. Material required, as I said earlier, the peripheral nerve stimulator, and a 22 gauge 25 to 50 mm insulated needle, and for blocks where the PNS is not used, a small hypodermic needle is sufficient. This is the cross section at the level of malleoli. This is the tibia, this is the fibula, so obviously this is the lateral side. As you can see, the tibial nerve, which lies behind the tibial artery. Then this is the deep peroneal nerve, lies by the side of the tibial artery, which becomes a dorsalis pedis at this level, little below it. Then these are the small branches, superficial peroneal nerve, sural nerve is somewhere here. So this anatomy has to be there in the mind when you are giving an ankle block. Coming to the first block, that is the tibial nerve block. Patient is in supine position with a slight external rotation of the leg. Landmark is the medial malleolus at tendo achilis. Then puncture site is anterior to the anteromedial border of the Achilles tendon, 4 to 5 centimeters above the medial malleolus. This 4 to 5 centimeters above is very important. Previously, with the blind technique, we used to inject by the side, both sides of the posterior tibial artery. But a calcaneal branch may get skipped when you go distally. So with the PNS, you go significantly proximally, and you will get a better block. This is the video of tibial block. You can see the landmark. This is the tendo achilis. I am slightly anterior to the anteromedial border, 4 to 5 centimeters above the medial malleolus. This is the response. It started with 1 milliampere current. Gradually, the assistant will go down to 0.4 milliampere. Response is still there at 0.4. It disappears below that. That is important. Again, he has increased it. The response reappears. The ankle block, recently within last 6 months after the discussion on the group, I have modified it and it has been now seen that we can use the peripheral nerve stimulus for locating the deep and superficial peroneal nerves also, that I will show later on. First, initially the way I used to do earlier for deep peroneal block, thinking that it's only a sensory nerve, so PNS cannot be used. These are the landmarks how to give deep peroneal block. Supine position with leg neutral. Landmarks are external hallucis longus laterally. I will directly show the figure. There are two different ways by which this can be blocked. Mark the external hallucis is on this side, tibial is anterior is on this side, and this is the dorsal spinatus artery. You can inject on both sides of the tibial artery, or inject the entry of the needle is here. You insert both the fascias, go up to the periosteum, come back, aspirate and inject. You have to be more on the external hallucis side. With newer understanding based on discussion on the Facebook group, PNS can be used to block the deep peroneal nerve in the groove between the tibialis anterior and external hallucis, where it is still a motor nerve. The elicited response is dorsiflexion of the toes. There is one more better video. I have gone a little proximally, somewhere here. Dorsiflexion of toes. I will go ahead. It's a big video. Superficial peroneal nerve, smaller of the two terminal branches of common peroneal. It perforates the deep fascia and distal part of the lateral leg and splits into lateral and medial branches. The branches continue on the dorsum of the foot. This is the figure. This is the area which is supplied by superficial peroneal nerve, except the first web slip. This is superficial peroneal nerve and its branches. So previously we inject in a band-like fashion above the lateral malleolus. So I will directly go to the alternative PNS technique. The entry point is in between the two peroneal muscles. This is the course of the nerve, sciatic nerve. It divides into two, tibial and common peroneal. Common peroneal goes here. It curves around the fibular head, divides into two. The superficial peroneal is in between the two peroneal muscles, where it can be blocked at the junction of the middle and distal 1/3. This is the video. Patient was getting a little bit pain, so I adjusted my needle. Eversion response. Here I am showing one interesting response. The response was there till the current of 0.2 milliampere. So I had to withdraw the needle a little bit. So probably I was intraneural. This is shown. See, I had to withdraw a little bit because I cannot inject if the response is there at a lower currents. There was fracture of two metatarsals. Okay. This is one more video, it is an older video. Same block. Sural nerve block is purely sensory nerve. Descends with lesser saphenous vein on lateral side of lower leg. It is situated subcutaneously on the lateral side of Achilles tendon and posterior to lateral malleolus. Supplies this part. Position and landmarks are described here. Subcutaneous injection in this fashion, it covers the area supplied by Sural nerve. Saphenous nerve block. Continuation of posterior division of femoral nerve. You inject in a fan-shaped manner on both sides of the greater saphenous vein. That is sufficient to block the saphenous nerve. Conclusion of ankle block. Complications. No specific reported. Advantages. Minimally invasive. Free from systemic effects. Reliable post-op pain control. Disadvantages. Painful to administer. Sedation is required. Limited tonic use is possible. Thank you. This is one orchid which I have shot in Uttarachal, and this I shot few days back. Gujarat. Because of Rajkot, I could catch